Okay, so today we're going to discuss some vascular abnormalities having to do mostly with veins and the pulmonary artery. So we'll talk about these topics here, the azygos vein, a little bit about SVC obstruction, pulmonary embolism, dual energy CT, and its implications for vascular imaging in the thorax, and pulmonary artery hypertension. So if we start with this case, we have a patient with a central venous catheter, and we notice that it takes this funny hook right over here in this region. So what is the significance of that? Well, in the lateral view, we can see that it is curving backwards, and this is what we see when a catheter is going into the azygos vein. So on the frontal view, when we see this hook at the tip of the catheter, it's an indication that the catheter is curving into the azygos vein, and here it is confirmed on the CT scan with this catheter going into the azygos vein. So that is something that you want to be able to recognize on the frontal chest radiograph. Here on our next case, we have a patient with two central venous catheters. The first one here has the tip overlying the right atrium. The second one, though, it comes down the left side of the mediastinum. So the question is, where is that going? And whenever you have a catheter that looks like it might be taking an abnormal course, the first thing you want to do is check to make sure there is blood return, to make sure that it is intravascular, and this catheter was intravascular. And this is the course that we would expect to see if a catheter is going into a persistent left superior vena cava, which is what we see here. So this vessel here represents a persistent left superior vena cava. So a persistent left superior vena cava will travel down and it will drain into a dilated coronary sinus, as in this case. Here's another example of a central venous catheter coming down the left side of the mediastinum. And when we see this kind of appearance, we need to suspect that the catheter is in a persistent left superior vena cava. So this will drain the left jugular and left subclavian vein, and it will drain to the coronary sinus, which is usually dilated, as in this venogram here. A right superior vena cava may or may not be present. It may be small, and there may or may not be communication between the left superior vena cava and the right superior vena cava via a small left brachiocephalic vein. So here we see a left superior vena cava there. As we follow it down, it is anterior to the left superior pulmonary vein, and then we will follow it down and it will drain into a dilated coronary sinus. Here it is on a coronal view, and we've already gone over these images where we can follow it on serial axial images all the way down into a dilated coronary sinus, which eventually drains to the right atrium. Now here in our next case, we have this right paratracheal rounded opacity. So what could that represent? Well, your differential diagnosis, of course, includes adenopathy. It might include a double aortic arch, although usually a right-sided arch, when you have a double aortic arch, usually the right arch is higher. Also, when there is a right aortic arch or double aortic arch, you would expect indentation on the trachea, which we really don't have here. So this represents a venous structure that is a dilated azygos vein. And so here it is traveling up the posterior mediastinum. There it arches forward there to drain into the superior vena cava. So why does this person have a dilated azygos vein? The answer is on the last image. Here is the dilated azygos vein. We note that the intrahepatic inferior vena cava is missing. So this is a condition called Azygos Continuation of the inferior vena cava. So this vessel here substitutes for the inferior vena cava. This is the azygos vein, and that will drain all of the blood return from the lower portion of the body. And a hallmark of this is that the intrahepatic IVC is missing. The hepatic veins will form a smaller IVC, which drains directly to the right atrium. So for the azygos vein on an upright chest radiograph, the azygos vein should not be greater than 1 centimeter in diameter. Here's the appearance of a normal azygos vein, this oval-shaped opacity. Really the azygos venous arch, as we are looking at it en face, as it curves forward to drain into the superior vena cava. So this will be seen here, adjacent to the right main stem bronchus, just above the right upper lobe bronchus. On a supine chest radiograph, The azygos vein should not be greater than 16 millimeters in diameter. The azygos vein gets smaller with upright positioning, deep inspiration, and Valsalva. Remember, with Valsalva, we are increasing intrathoracic pressure, and that will squeeze on the veins, so the veins will get smaller with Valsalva. Now, it is important to try to differentiate enlargement of the azygos vein from lymphadenopathy in the right paratracheal region. Common causes of enlargement of the azygos vein: CHF, actually anything that increases right-sided cardiac pressure or increases central venous pressure will result in distension of the azygos vein. Obstruction of the SVC, obstruction of the IVC. The azygos vein is an important collateral vessel in those circumstances. Portal hypertension. So patients with portal hypertension will develop shunts from the portal to the systemic venous system, and that can result in dilatation of the azygos vein. Pregnancy can also result in dilatation of the azygos vein from all of the added blood return from the lower portion of the body. And we've discussed azygos continuation of the IVC, and of course there's always idiopathic for that. Rare causes: constrictive pericarditis, pericardial effusion, aneurysm, and arteriovenous fistula. So with azygos continuation of the IVC, we can follow the azygos vein all the way up until it arches forward here to drain to the superior vena cava. And as we've said, the hallmark is absence of the intrahepatic portion of the IVC. Now, if I just gave you these two slices from the abdominal CT scan, you should be able to suspect that this patient has azygos continuation of the inferior vena cava. Now, why should we suspect that? Well, this vessel here is not the inferior vena cava. This is too posterior to be the IVC. Notice the right renal artery is coursing anterior to the vessel. The right renal artery usually courses posterior to the inferior vena cava. So this represents the azygos vein, which has embryologically formed here and formed in a more posterior location than the inferior vena cava. And this then substitutes for the inferior vena cava, draining the lower portion of the body. So we can follow that vessel all the way up as the azygos vein here, and it will arch forward to drain to the superior vena cava. And of course, it will be dilated because this is a case of azygos continuation of the inferior vena cava. So when we have a normal inferior vena cava, the right renal artery normally passes posterior to the normal inferior vena cava. On the other hand, if we have azygos continuation during embryology, this vessel, being the azygos vein, forms more posteriorly than the normal inferior vena cava. Hence, the right renal artery will be coursing anterior to the vessel. So just with those images through the abdomen, you might be able to suspect that the patient has azygos continuation of the inferior vena cava. So right renal artery passing anterior to the vessel, then that vessel represents the azygos vein. Okay, let's move on to our next case. So here we're looking at a set of serial CT, axial CT images through the chest in a patient who's received intravenous contrast. We're struck by all of these dense collateral veins all throughout the mediastinum and also along the chest wall. Now, when we're dealing with vascular issues, also around the liver, it can be helpful to look at these images in vascular windows. And vascular windows are wider windows, so width of 800, level of 100. It's easier to see the differences in the opacification of the vessels between the arteries and the veins when we widen the windows. So now when we look at this and we follow the contrast, we can see that there's a superior vena cava, and then there seems to be an obstruction there. And it turns out that this patient has a central venous catheter, and there is a large thrombus right at the tip of the central venous catheter, which is actually extending along the left brachiocephalic vein, producing obstruction of that also. So this patient has superior vena cava syndrome from this large thrombus obstructing the superior vena cava that is formed at the tip of this catheter. Now, what is interesting here is just below the obstruction, just below that thrombus, if we look at the superior vena cava below the thrombus, so let's follow that as we follow right below the thrombus. Here is the superior vena cava. It is opacified, but it is not as dense as the collateral vessels or the undiluted contrast that we have injected into the right arm. So there's the dense contrast. Follow that down, and there's the superior vena cava just above the right atrium. So what is going on here? So here are these collateral vessels full of undiluted contrast that are opacifying around the mediastinum, so we can see those clearly. Here is the catheter with the thrombus at the end of it producing the SVC obstruction. But just below the catheter and the obstruction, here is the superior vena cava right above the right atrium. So how did that remain patent? Why didn't the thrombus propagate down all the way through the SVC? That is because this portion of the SVC has been kept patent by flow through the azygos vein. So here's the arch of the azygos vein, and that is what has kept the superior vena cava below this obstruction patent. So what are causes of SVC obstruction? Well, of course, we can have lung cancer, all kinds of mediastinal malignancies, mediastinal fibrosis, thrombosis around a central venous catheter. As we have seen, we're all familiar with the symptoms of SVC syndrome. So when we have SVC obstruction, there's lack of opacification of the SVC. We will see dense undiluted contrast within collateral vessels. You might also notice a big azygos vein that is acting as a collateral source. Here's another example from lung cancer here. There's complete obstruction of the superior vena cava. Notice these collateral veins in the mediastinum with undiluted contrast. And here is the azygos vein here. Now, it is important when we're thinking of obstruction of the superior vena cava to think of it in two segments. There's the segment above the junction with the azygos vein and the segment below the junction with the azygos vein. If there is supra-azygos obstruction of the superior vena cava, so if the azygos vein is obstructed above its junction, if the superior vena cava is obstructed above its junction with the azygos vein, then the azygos vein can keep the superior vena cava below the obstruction patent, as it is carrying blood into the superior vena cava. So here's a patient with lymphoma who has obstruction of the superior vena cava above the azygos vein. When we get to the junction of the azygos vein, we can see this undiluted contrast that is gotten here through collateral pathways, and now that is going into the superior vena cava below the obstruction, and that helps to prevent the thrombus or obstruction from propagating down the superior vena cava. So here's the azygos vein carrying blood flow to the superior vena cava, keeping the caudal portion of the superior vena cava patent. On the other hand, if we have obstruction below the junction with the azygos vein, now the azygos vein will carry blood away from the superior vena cava above the obstruction, and it will carry that blood to try to collateralize with the inferior vena cava. So this patient has obstruction here in the superior vena cava just below its junction with the azygos vein. Again, this is a patient with a central venous catheter here. And now we see this undiluted contrast within the azygos vein, but here the blood flow is moving away from the superior vena cava down the azygos vein, and then from here it will go into collateral vessels to try to collateralize to the inferior vena cava. So when we have obstruction of the SVC, it is important to think of it in two segments: obstruction either above or below the junction with the azygos vein. And we can see how the azygos vein helps to maintain the blood flow and the collateral circulation. Here's a patient who has obstruction of the superior vena cava, but note here this abnormal enhancement within the liver adjacent to the falciform ligament. So in patients who have central venous obstruction as a result of collateral pathways that come down through the abdominal wall to the paraumbilical veins, we may see abnormal enhancement here within the liver. And if you've only done a CT scan of the abdomen and you notice something like this, it's important to consider central venous obstruction, and that might merit scanning the chest looking for central venous obstruction. Here's another example. This patient had surgery and had ligation of the brachiocephalic vein, developed all these collaterals along the chest wall. You can see the collaterals along the anterior chest wall. These are collaterals to the paraumbilical veins here, and this is causing enhancement within this portion of the liver. So abnormal enhancement on an abdominal CT scan like this within the liver can be an indication of collateral vessels here carrying undiluted contrast because of obstruction of the SVC or central venous obstruction. Okay, so let's move on to our next topic. So here we have a chest radiograph, and when we compare one side to the other, we notice that there is some increased lucency here. And as it turns out, this is from decreased blood flow. That is oligemia in a patient with pulmonary embolism. So this is an example of the Westermark sign, where we have oligemia because the blood flow is shunted away from this region because of the pulmonary embolism. Other signs we might see with pulmonary embolism, here we have this peripheral consolidation. So this is an infarct. This represents Hampton's hump. And also notice the enlarged central pulmonary artery. That is also called Fleischner's sign, the Fleischner sign. These are additional signs that we might also see associated with pulmonary embolism. So here's our pulmonary embolism here. Here is our peripheral infarct manifesting on the chest radiograph as Hampton's hump. Pulmonary embolism, most emboli here get to the lungs from clots in a deep venous system. And here on the CT scan through the legs, we can see the clot there in the popliteal vein. And this patient has bilateral pulmonary embolism as a result of that. And pulmonary infarction can be seen in these cases. Usually requires inadequacy of the bronchial arterial circulation. So patients may have heart disease or CHF in addition to pulmonary embolism to develop a pulmonary infarct. So consolidations that we see on chest radiographs associated with pulmonary embolism may represent pulmonary infarcts or may represent pulmonary hemorrhage. If it's pulmonary hemorrhage, it clears rapidly within less than a week, whereas an infarct takes longer to clear, and an infarct usually resolves over several months as it kind of resolves from the periphery. That's called the melting ice cube sign, and often there may be a residual linear scar after the infarct has resolved. We might see cavitation within pulmonary infarcts. Of course, we can see that with septic emboli, but sometimes this is an example of a patient with septic emboli, and here's a large cavitation here. But sometimes with large infarcts, you may get aseptic cavitation. So if an infarct is greater than 4 centimeters, you may get cavitary change even without infection. So in most cases, the chest x-ray is normal in patients who have pulmonary embolism. Some of the signs we've already discussed. Westermark sign is oligemia. We might see atelectasis as a result of depletion of surfactant. So our example of Westermark sign here. If there's infarction, then we might see Hampton's hump, this wedge-shaped peripheral opacity. And as we've mentioned, we might also see atelectasis or pleural effusion and the enlarged central pulmonary artery here on the side of the embolism. That is called the Fleischner sign. Now, as far as the protocol, the CT protocol, when we're doing CT for pulmonary embolism, thin slices, thin reconstruction, intervals, we want to make sure we give enough IV contrast at a high flow rate, at least 4 millimeters per second. Usually we use about 100 cc's of contrast in our patients, although with the faster scanners, you can get away with less, 80 cc's or even less in some cases. The scan delay we like to use bolus tracking or smart prep, as it is called on the GE scanners. So there we take some low dose images over the pulmonary artery every 1 or 2 seconds until the contrast opacifies the pulmonary artery, and then we start scanning. Coverage, we want to scan the whole chest. Now with the older CT scanners, this used to be done from the bottom up. So what was happening here is that because with older CT scanners, it could take about up to 20 seconds to scan the entire chest, which is a long breath hold. And since most pulmonary emboli tend to go to the lung bases, it was important to get images through the lung bases with a minimal amount of motion artifact. So the scan would be started from the bottom up, and by the time you got to the top of the lungs, the patient may be breathing, but there was less likelihood of finding pulmonary emboli there anyway. Now with the modern scanners, you can scan the whole chest in less than 5 seconds, so whether you scan from the top down or the bottom up probably does not make a difference. As far as the instructions for respiration, we want to give the instruction of stop breathing or don't breathe. You don't want the patient, what you want to avoid is you don't want the patient taking a deep breath right before the CT scan, and then we'll talk about the reasons why in a few minutes. So the appearance of pulmonary embolism on CT, central filling defect with contrast around it. And we may have parenchymal abnormalities as we've discussed before, pulmonary infarcts, these wedge-shaped peripheral opacities, and sometimes you can follow the clots within the small pulmonary vessels going right up to the apex of this pulmonary infarct, the so-called feeding vessel sign. So of course, CT has high sensitivity and specificity for central pulmonary emboli. Very small clots may be missed, but they may not matter that much. We can see these segmental clots fairly easily on modern scanners. Now, pulmonary emboli, these tend to lodge at the bifurcations of vessels. So you can think of these as casts of veins from the lower extremity. So these are like strings of linguini. And when they embolize into the pulmonary vasculature, they will get stuck at the bifurcation of vessels. So here in this example, as we follow the pulmonary arteries down, you can see that filling defect bridging bifurcation of the vessel. So here it is here, and then here on a cut slightly lower, you can see it bridging that, and very nicely demonstrated here on this reformatted image. On this reformatted image, we can see that clot bridging the bifurcation of the vessel. If you see that, of course, that increases your confidence that you are dealing with a pulmonary embolism. This is a problem we often come across when we're doing CT for pulmonary embolism. Why is this such a bad scan? Why is there such suboptimal opacification here of the pulmonary arteries? Was it scanned too early? Was it scanned too late? Was there a contrast injector malfunction? Well, we can see that there is contrast within the aorta, so it was not scanned too early. We still see contrast pouring down the superior vena cava, so it was not scanned too late. So if we have contrast coming down the SVC and we have contrast within the aorta, why isn't there good opacification of the pulmonary artery? Well, the answer is down here. If we look at the right atrium and the right ventricle, we notice that the contrast has been diluted within the right-sided chambers. So what is diluting that contrast? That is unopacified blood that is coming up from the inferior vena cava into the right-sided chambers, and that can dilute the contrast. And that happens if the patient takes a deep breath just before we scan, because taking in a deep breath will increase the blood return from the inferior vena cava, and that will dilute the contrast in the right-sided chambers. So in expiration, that prevents blood from coming up the IVC. You can see dense opacification of the right-sided chambers here. In early inspiration, this increases flow into the heart from the inferior vena cava, and that will dilute out your contrast. So this phenomenon is called transient interruption of contrast. And what can happen is if the patient takes even while you're injecting the contrast, if the patient takes a deep breath just before you scan, then we will get this bolus of unopacified blood that gets into the right-sided chambers and then into the pulmonary arterial circulation here, and then that can give you suboptimal opacification of the pulmonary vasculature. Sometimes when we have a really good CT scan with great opacification of the right-sided chambers and pulmonary vasculature, that is because of poor cardiac function. If there is poor cardiac function and poor cardiac output, the circulation time is delayed and the contrast kind of sticks to the pulmonary arteries. So with poor cardiac function, you get delayed circulation time. Often you get very good PE scans. And in young, healthy patients who have very good cardiac function with very fast circulation times, the contrast can pass through the pulmonary circulation very quickly. And poor CT scans for pulmonary embolism, so it's notorious for getting that in pregnant women because they will have a large amount of unopacified blood that will be returning to the right side of the heart from the inferior vena cava. Now, here's another patient who has bilateral pulmonary embolism, but there's another observation that is very important for us to make, and that is the fact that we have this dilated right ventricle. Notice that the right ventricle here is more dilated than the left ventricle. It's pushing the interventricular septum off to the left side. The right atrium is also dilated. So this patient has right heart strain, which does increase the risk of morbidity from pulmonary embolism in these patients. So that is an important observation. So patients with right heart strain need to be treated more aggressively since they are at higher risk for morbidity and mortality from pulmonary embolism. So usually these patients have large central clots, as you can see here, and then here's the dilated right ventricle, dilated right atrium, and on this short axis view we can see the dilated right ventricle in this patient with right heart strain. Now it turns out the more dilated the right ventricle when we have these massive pulmonary embolism, the worse the prognosis. Here is your right ventricle to left ventricular ratio, and you can see that as the right ventricle dilates more and more compared to the left ventricle, the prognosis is worse. Also, what happens is as the right ventricle dilates, pushing on the interventricular septum, that decreases the ability to fill the left ventricle, which decreases cardiac output from the left side of the heart. It's very bad also for the coronary circulation, and that can lead to circulatory collapse. Also, when the right atrium dilates, that can push on the interatrial septum and restrict filling of the left atrium, again contributing to underfilling of the left side of the heart. So when there's massive pulmonary embolism, acute cor pulmonale is the usual cause of death from this massive distension of the right-sided chambers. So let's move on to our next topic. So our next topic, spectral CT, dual energy CT, multi-energy CT, all of these mean the same thing. And with dual energy CT, what we are doing here is we're taking advantage of the photoelectric effect. So what happens is, as a photon comes in here to a particular atom, if the energy of the photon is close to and slightly above the K-shell energy of one of the electrons, it will be completely absorbed by the electron. The electron goes flying off, and then that, of course, contributes to the ionizing radiation as all that energy is deposited within the patient. However, this is very good for imaging because that photon has been completely attenuated without any scatter. So iodine here, if we examine iodine and its change in attenuation as we go across the spectrum of energies that we commonly use when we're doing diagnostic imaging, iodine shows the greatest change in attenuation over this range of energy. So iodine is a very good contrast agent for diagnostic imaging. So as we get close to the K-shell edge of 33 keV, the attenuation of iodine jumps up, spikes up there because of the photoelectric effect. And when you compare iodine to calcium and water here, you can see that the change in the attenuation of iodine is quite dramatic. And here when we look at, when we examine this in Hounsfield units, it's even more dramatic. So here is the attenuation of iodine across a range of X-ray energies that we like to use for diagnostic imaging. Now, water does not change much at all. You see the attenuation of water stays at 0, whereas calcium changes a little bit, not as much as iodine. And hydroxyapatite here, which is the mineral found in bone and teeth, also changes very slightly, but again, nothing is as good as iodine there as a contrast agent. Now, we can take advantage of this because it turns out that at lower X-ray energies, because the attenuation of iodine actually increases, the iodine gets brighter. So here these are kind of virtual reconstructions at lower energies to show you what the contrast looks like. And you can see as we decrease the energy down to 40 keV, the iodine here gets quite bright. So this is how we would use dual energy for material decomposition or for analyzing the material within a patient when we're using dual energy CT. So we scan at two different energies, and CT might scan at 80 kV or 140 kV. Those are the two energies that are generally used for dual energy CT. Now, the attenuation of water does not change at all. It remains 0 Hounsfield units at both low energy and high energy. However, if we look at soft tissue that may have some iodine in it as a result of administration of intravenous contrast, here at the high energy, the attenuation there is somewhat less than 100 Hounsfield units in this particular example, maybe close to 90. However, when we look at low energy, there's markedly increased attenuation of that area there containing some iodine. It's close to 140 Hounsfield units. So what happens is the tissue is scanned both at high energy and low energy, and the software examines each voxel to see how the attenuation changes between the low and high energy, and determined by how much it changes, the software can decide how much iodine or what substance, how much of any particular substance is within that voxel. And so then we can manipulate the images and do post-processing to bring out the iodine, to bring out the contrast, and to actually increase the effect of contrast enhancement. So, of course, the German word that is used to describe radiation produced in an X-ray tube, that is Bremsstrahlung, or braking radiation, as these electrons slow down when they hit the tungsten target. That's what releases the X-ray beam. So if we ask the question, what kV settings are available for CT scanning, it turns out that these are limited. So you can set the CT scanner at 80 kVp, 100 kVp, 120, or 140. Those are your standard settings. Now, kVp stands for peak kilovoltage. So what is the average energy of the X-rays in kiloelectron volts if you use a peak kV or kV peak of 140 on your CT scanner? Well, if our kVp is 140, that will represent the peak energy. That's the highest energy photon will be at 140 keV. But actually, there's a whole range of energies that are produced here, and the average energy, if you're scanning at 140 kVp, is almost half of that, about 76 keV. You can see the broad range of energies that are produced. The same thing is true, similar phenomenon occurs if we scan at 80 kVp. Average energy is close to about half of that, or 56 keV. So you can see that if you scan at 80 kVp, the highest energy photon will be at 80 kiloelectron volts, but there's a whole range of energies here that are produced. These particular spikes represent a characteristic radiation there produced by the target itself, specific to the tungsten target. But the point is, you get a range of energies here that are produced in the X-ray beam whenever we do CT scanning. So the X-ray beam is polychromatic, not monochromatic. It's not at one single energy. It is at a range of energies. And with dual energy CT or dual spectral CT or spectral CT, what we try to do is we try to take advantage of the difference in this range of energies between high energy and low energy scanning to decide on the material composition of what it is that or particular materials that we're interested in, usually iodine, within the soft tissues. So how do we do dual energy CT? Well, there's the simple way is dual spin, where you scan the patient once at low kVp and then scan again at high kVp. But of course, this is extremely inefficient. You also get misregistration artifacts, as there can be motion, as these are two completely separate scans. Now, Siemens does this kind of dual energy scanning with dual source CT. You have two X-ray tubes. These are placed 90 degrees to each other. So one scans at low energy, one scans at high energy, and then the data is collected. And then GE does this with fast kV switching using one X-ray tube, but that X-ray tube, the energy is changed very quickly between 80 and 140 kVp, and the data is collected. and GE calls this GSI, or gemstone spectral imaging. Other ways to do this, there are dual layered detectors. There are detectors that can be sensitive to low energy, and another set of detectors here, different layer that is sensitive to higher energy. And then so this is used to separate out the amount of attenuation produced by the different energies. And then the most recent way of doing this is with photon counting, where this polychromatic beam actually goes through the patient, and then the detectors are actually able to count not only the photons but the energy, determine the energy of the particular photons that are traveling through the patient, and that is called photon counting. Now, these reconstructions that we can get are really virtual monochromatic images. So this is all done with post-processing, so we can generate these reconstructions. And as if the patient was scanned at 40 keV, this is what the image would look like. This is what the image would look like if the patient were scanned at 200 keV. So you can see as we dial down virtually this keV setting, the iodine gets much brighter. And so here on your standard image, if we don't have a very good bolus, it might look like this. But when we dial down the keV and do this virtual reconstruction, now we can really bring out the contrast within the pulmonary arteries. So we can convert a not so good CT angiogram into a pretty good CT angiogram using this principle of the dialing down the keV on these virtual reconstructions. Now, since we know where the iodine is, we can make it look brighter with lower keV settings, or we can subtract it out. Post-processing again, so we can generate these virtual non-contrast images. So the patient was only scanned once after administration of intravenous contrast, and then the software can determine where the iodine is and actually subtract it from the image, so giving you these virtual non-contrast images. And in patients who have renal failure, where you're limited as to the amount of contrast that you can use, with only a small amount of contrast, you can get diagnostic CT angiograms. So here with 20 cc's of contrast, your conventional image does not look very good, but when we dial down the keV to 40 on this virtual reconstruction, now we have a pretty good CT angiogram there of the ascending aorta. This is an example where we had a not very good opacification of the pulmonary arteries, and if this was done, this case was done with dual energy, and of course the advantage of that is we again dial down that keV here, and we can make the iodine much brighter, and it's much easier to interpret the pulmonary vasculature. Here's a case where on the conventional images we're wondering if there's a clot there within the left interlobar pulmonary artery. The bolus here is not very good. When we do these virtual reconstructions, dialing down that keV now, the iodine looks much brighter. Now we can actually see the clots a little better, increasing our confidence that this patient has pulmonary embolism. So here are the images side by side. At the standard settings here, we can see that the opacification of the vasculature is not very good, but when we dial down the keV here now, we can see the clots a little bit easier. And then here on these reformatted views, much easier to see the clots there. Now we can also look for the iodine within the lung parenchyma in this patient with pulmonary embolism. If we make the images sensitive for the iodine in the lung parenchyma now, we can see that there is a bit of a perfusion defect here comparing the right lower lobe here to the left lower lobe. And you can see that a little bit more dramatically in these color-coded images, comparing the right side to the left side. Here is the clot there in the right lower lobe, and we can see that the perfusion there in the right lower lobe is also decreased. And as we've said, just like we can make the iodine brighter, we can also remove the iodine and generate these virtual non-contrast images. Here's another case of pulmonary embolism, and then here we have a perfusion defect there in the right lower lobe. Beam hardening artifact. So when we have dense contrast, this is an artifact that we might see, but to get rid of this, we just do virtual reconstructions at a higher keV, and we can eliminate some of that beam hardening artifact there. So here is a very nice example of how we might use this. This is a patient who had atrial fibrillation, and on the conventional CT scan, we see what looks like a filling defect here within the left atrial appendage. We're wondering, is that clot or is that just slow filling of the atrial appendage? So this was done with a dual energy protocol. So here, when we dial down that KEV on these virtual reconstructions now, we can see that all of this, actually, there is iodine here at the tip of the left atrial appendage, so there is no thrombus there. And this was also confirmed in this particular case with delayed imaging, showing us that there is no thrombus there within the left atrial appendage. All right, so let's move on now to a discussion of pulmonary hypertension. The definition of this is sustained elevation of pulmonary artery pressure. So here the resting mean pulmonary artery systolic pressure be greater than or equal to 25 millimeters of mercury. So the strict definition of pulmonary arterial hypertension, so the term pulmonary hypertension itself just means elevated pulmonary artery pressure, but pulmonary arterial hypertension, that means that we have elevated precapillary pulmonary resistance with normal pulmonary venous wedge pressure. So this is referring to the Dana Point Group 1 classification of pulmonary hypertension. So the terms pulmonary arterial hypertension, this term is slightly different. The meaning of this term is slightly different than the meaning of the term pulmonary hypertension. So that's just a fine point. Usually, though, those terms are used interchangeably. So the Dana Point classification of pulmonary hypertension, this is what is used by the medical types to categorize pulmonary hypertension. The first classification is pulmonary arterial hypertension here. So this can be, in this group, we can have idiopathic pulmonary hypertension from congenital heart disease, portal pulmonary hypertension from HIV or drugs. Then the second category is pulmonary venous hypertension that secondarily causes elevated pulmonary artery pressures, or secondarily causes pulmonary artery hypertension. And here the two most common diseases are chronic left ventricular failure and mitral stenosis. Then we have pulmonary hypertension associated with hypoxemia. So we can see this with COPD, interstitial lung disease, or sleep apnea. Pulmonary hypertension from thromboembolic disease. So we'll see that with chronic PE and sickle cell disease. Pulmonary hypertension from a disorder directly affecting the pulmonary vasculature, like sarcoid, Langerhans cell histiocytosis. So the point of this classification scheme is that it can also determine the particular treatment that you might offer the patient. So what happens with pulmonary hypertension is that with sustained elevation of the pulmonary artery pressures, you get intimal proliferation and medial hypertrophy, as in this example here. What that does is that elevates the pulmonary vascular resistance, which then makes the pulmonary hypertension worse, and then you develop this vicious cycle of worsening pulmonary hypertension and then increasing the pulmonary vascular resistance. Now, as far as a radiological approach, I find the easiest radiological approach for us as radiologists to approach pulmonary hypertension is to divide it into precapillary, capillary, and postcapillary causes of pulmonary hypertension. So the precapillary causes, these are things that increase flow through the pulmonary vessels, so left to right shunt. These are the three most common, left to right shunt. Occasionally increased total blood volume, as in these diseases also, might elevate pulmonary arterial pressure. But left to right shunts, we don't want to forget about those, especially atrial septal defect, which is the most common to present in the adult. Now, the second category of diseases that decrease the cross-sectional area of pulmonary vessels. So diseases causing obstruction, like chronic PE, primary pulmonary hypertension, vasculitis, schistosomiasis, and then pulmonary capillary hemangiomatosis, which we will cover later. And then also in this category would be diseases that result in chronic hypoxia, because this results in destruction of pulmonary blood vessels, and that results then in a decreased amount of, if you will, the total cross-sectional area available for blood flow through the lungs. So we can see that, of course, with emphysema and pulmonary fibrosis. And then the third category here is pulmonary venous causes. So we've discussed the precapillary causes, left to right shunt. We can think of obstruction of the pulmonary arteries, and capillary causes is our second category. And then here the third category is pulmonary venous hypertension. That secondarily causes pulmonary artery hypertension. And here the two biggest abnormalities in this category are chronic left ventricular failure and mitral stenosis. Now, when we have pulmonary hypertension on chest radiograph, we will get right ventricular enlargement and enlargement of the central pulmonary arteries. In long-standing cases, you might get pulmonary artery calcification, especially with Eisenmenger Syndrome. If the cause of the pulmonary hypertension is pulmonary venous hypertension, then you may see evidence of pulmonary venous hypertension. So if we're evaluating the chest X-ray, and we have enlarged central pulmonary arteries, and we're thinking of pulmonary artery hypertension, if there is no lung disease, consider Eisenmenger Syndrome, chronic PE, and idiopathic or primary pulmonary hypertension. If there is lung disease, then what is the particular lung disease? Or is it emphysema, or is it fibrotic lung disease? If there's evidence of pulmonary venous hypertension, then here we would think about mitral stenosis and chronic left ventricular failure. Those are the two most common causes in this category. And then there can be other rarer causes of pulmonary venous obstruction, like pulmonary veno-occlusive disease. So here's a case of enlarged central pulmonary arteries. Notice here, though, that there's a little bit of peripheral calcification here of the pulmonary artery. So we can see that in long-standing cases of pulmonary hypertension, enlarged central pulmonary artery there with pulmonary artery calcification. This is a patient with central lobular emphysema and COPD. So this patient had pulmonary hypertension secondary to the underlying lung disease. Now, what are the CT findings associated with pulmonary hypertension? Well, we have enlarged central pulmonary arteries. We want to look here at the main pulmonary artery. So at this level here, the main pulmonary artery should be about the same diameter as the aorta. So if the main pulmonary artery is more dilated than the aorta, then we might consider pulmonary hypertension. Other things we can find: dilatation of the right ventricle, right atrium, because of tricuspid regurg from the dilated right ventricle. Also right ventricular hypertrophy, and then enlargement of central vessels with small caliber of the peripheral vessels. This is called pruning, as the peripheral vessels are small, out of proportion to the enlargement of the central pulmonary vessels. MR findings associated with pulmonary hypertension or right ventricular pressure overload. Well, the right ventricle can be dilated, as in these examples. We see a dilated right ventricle. And also, you might get pulmonic valve regurgitation here. You can see that there's some regurgitation there going back. And then on myocardial delayed enhancement, we might see some abnormal enhancement here at the insertion of the right ventricle on the interventricular septum. And this is thought to occur because of a small amount of fibrosis that occurs in these regions as a result of the abnormal strain and the abnormal pressures here induced on the right ventricle. So these are called the hinge points, the insertion points of the right ventricle onto the interventricular septum. So findings of right ventricular pressure overload. Here on this MR, we can see flattening of the interventricular septum. Notice the marked dilatation of the right ventricle and right ventricular hypertrophy, and also this D-shaped left ventricle as a result of the right ventricle pushing on the interventricular septum. So in adults, whenever we see a dilated right ventricle and big pulmonary arteries, we need to think about Eisenmenger Syndrome, which can cause severe pulmonary artery hypertension. This is when we have what started out as a left to right shunt that converts actually to a right to left shunt and can cause cyanosis as a result of elevation of the pulmonary vascular resistance and pulmonary artery pressures. So this can occur secondary to a VSD, but can also occur from ASDs or PDAs, and in more severe congenital heart diseases with bidirectional shunts like transposition. Patients with transposition also have a VSD. Now, when in the Eisenmenger stage, the pulmonary blood flow can actually be decreased, and if there is pulmonary edema and cardiomegaly, it might improve, but at the expense of worsening cyanosis, since we are converting a left to right shunt into a right to left shunt. So Eisenmenger's in adults gives you the largest central pulmonary arteries that you will ever see. So if you have an adult with massive enlargement of the pulmonary arteries, think about Eisenmenger's. This was a patient who had an atrial septal defect who developed Eisenmenger's. The right-sided chambers will also be enlarged in these conditions. So here's a case with marked enlargement of the pulmonary artery, and because of the elevated pulmonary artery pressure, these patients can also develop atherosclerotic disease. So here you see atherosclerotic disease here along the wall of the pulmonary artery, and pulmonary and calcifications within the wall of the pulmonary artery. Now in this example, we have some thickening, eccentric thickening here of the pulmonary artery there on the right, and here we can see an eccentric filling defect here along the left interlobar pulmonary artery. So also some right ventricular hypertrophy. So what does this represent? This is chronic thromboembolic disease. So this can occur when pulmonary embolism does not lyse properly, or if there is recurrent pulmonary embolism, then the pulmonary emboli, these pulmonary emboli here, instead of resolving, can become incorporated into and organized and incorporated into the wall of the pulmonary artery, which can result in pulmonary artery hypertension. So the hallmark of this is we can have eccentric thickening like this, or eccentric filling defects along the walls of the pulmonary arteries. We can see webs. So these webs represent incomplete recanalization. So we can see webs within the pulmonary arteries, as in this example. And then another finding that we can also see is this mosaic perfusion, as the blood flow is shunted away from these areas where there is pulmonary vascular obstruction to these other areas of the lung, increasing the attenuation and causing these diffuse areas of lower attenuation. So here's a patient with eccentric filling defect in the right pulmonary artery, and also there's some circumferential thickening there of the left interlobar pulmonary artery. So this is a patient with mosaic attenuation from chronic pulmonary thromboembolic disease. So a more specific term here is mosaic perfusion, and this is when we have these areas of decreased attenuation with smaller blood vessels. Notice the blood vessels are somewhat larger and more prominent in the areas of the lung parenchyma that are increased in attenuation, because the blood flow is diverted away from these areas where the pulmonary vasculature is obstructed. So this is called mosaic perfusion, and this can also be seen in patients with chronic pulmonary thromboembolic disease. How can we differentiate this from air trapping? Well, air trapping usually breaks down into pulmonary lobules, into secondary pulmonary lobules of air trapping, and mosaic perfusion, when it occurs secondary to vascular disease like chronic pulmonary embolism, usually more diffuse. And also on expiratory imaging, if you do expiratory imaging, the air trapping will be accentuated. Also, if we have mosaic perfusion here from chronic thromboembolic disease, you would expect to see these dilated central pulmonary arteries because of the pulmonary artery hypertension. So this patient has a large chronic pulmonary embolism. What else is abnormal in this patient? Notice all of these vessels here in the mediastinum. These are dilated bronchial arteries. So dilated bronchial arteries can also be associated with chronic thromboembolic disease, as these try to collateralize also to the lung parenchyma. What parasite is associated with pulmonary hypertension? Of course, the answer is Schistosomiasis. So this parasite can also obstruct the pulmonary vasculature, and worldwide, this apparently is not an infrequent cause of pulmonary artery hypertension. Idiopathic pulmonary hypertension is a diagnosis of exclusion, but this will also give you marked enlargement of the main pulmonary artery and enlargement of both the right and left pulmonary artery. So in the lateral view here, we can see that the right and left pulmonary arteries here are superimposed and enlarged. Here's the left pulmonary artery going up and over the left upper lobe bronchus. Pulmonary outflow tract here is also somewhat dilated in this patient. So primary pulmonary hypertension or idiopathic pulmonary hypertension, usually female patients, 10% might have Raynaud's. It is a diagnosis of exclusion, as other causes must be ruled out. The findings on the chest radiograph, same as the findings in all of those other usual cases of pulmonary hypertension, marked enlargement of central pulmonary arteries and enlargement of the right heart and pulmonary outflow tract. Here we have another patient with marked enlargement of the central right and left pulmonary arteries. So why does this patient have pulmonary hypertension? Well, we notice the hyperinflation. We notice the emphysematous changes here, flat diaphragms. This is a patient with COPD. And emphysema, as in this patient, is probably the most common cause of pulmonary hypertension in the United States. Note the marked enlargement of the pulmonary arteries here, enlargement of the right ventricle and the right atrium. Severe emphysema in this patient causing pulmonary hypertension. Another case of an enlarged main and central pulmonary arteries. This time we notice a little bit of vascular redistribution here, and also the left atrium is somewhat enlarged. So in patients with enlarged left atria and pulmonary hypertension, we want to think about mitral stenosis. So these patients will have enlarged pulmonary arteries, evidence of pulmonary venous hypertension, and enlargement of the left atrium. So with mitral stenosis, these patients develop enlargement of the left atrium, develop pulmonary venous hypertension, and then secondarily develop, as a result of that, pulmonary artery hypertension. Rheumatic heart disease is the most common cause of mitral stenosis. These patients may also have some component of mitral regurgitation, and they will have enlargement of the left atrium and the pulmonary vasculature. So we look for signs of enlargement of the left atrium, the double density sign behind the right heart border. Also look for signs of pulmonary venous hypertension, cephalization, interstitial edema, curly B lines. These patients can go on to develop pretty severe pulmonary hypertension. So this patient has pulmonary hypertension with normal pulmonary capillary wedge pressure. There's enlargement of the main pulmonary artery here, enlargement of the right ventricle, as you would expect in this patient with pulmonary hypertension. But also notice that there's interlobular septal thickening here. So it seems like the patient has interstitial edema, but the left atrium is normal. The patient does not have left-sided heart failure. So pulmonary venous pressure, the pulmonary capillary wedge pressure, which is a measurement, indirect measurement of the pressure here in the left atrium, is normal. So the left heart here is normal. So why does the patient have then interstitial edema and pulmonary hypertension? The answer here is pulmonary veno-occlusive disease. So in this disease, these patients develop intimal fibrosis that narrows and occludes the small pulmonary veins, usually in young patients. Can be associated with pregnancy, bone marrow transplant, chemotherapy, viral infection, or autoimmune disease. So these patients will develop obstruction of the small pulmonary venules there, which can result in pulmonary venous obstruction on the microscopic level and interstitial edema, but the left atrium is normal, so the pulmonary capillary wedge pressure will be normal in these patients, even though it looks like, or they do have, interstitial edema. So it's pulmonary veno-occlusive disease. They can have enlarged pulmonary arteries from pulmonary hypertension. They can have interstitial edema with a normal left atrium, normal pulmonary capillary wedge pressure. And on CT, in addition to the enlarged central pulmonary arteries, we might see some interlobular septal thickening as a result of the interstitial edema in these patients. So pulmonary veno-occlusive disease, signs of pulmonary hypertension with signs of pulmonary venous hypertension or interstitial edema here, but with a normal left atrium. More examples here. These patients can also develop pleural effusions, some transient lymphadenopathy, interlobular septal thickening, some ground glass opacities here as a result of the pulmonary venous hypertension in these patients. Now, if I tell you this patient has pulmonary artery hypertension, also has normal pulmonary capillary wedge pressure, but this time we have centrolobular ground glass attenuation nodules. What are we dealing with here? Now we're dealing with pulmonary capillary hemangiomatosis. So here we have proliferation of thin-walled capillary channels in the pulmonary interstitium, and this causes obstruction of small venules. So these fragile capillaries can bleed, which can result in hemoptysis, and that's these petechiae here on gross exam, and that's what gives us the centrolobular ground glass opacity. So that represents a little bit of bleeding there within the lungs. These patients will also have pulmonary hypertension with normal pulmonary capillary wedge pressure, so they can have enlarged central pulmonary arteries from the pulmonary hypertension, some reticulonodular opacities, and the nodules represent areas of petechial bleeding. So these centrolobular ground glass opacities here within the lungs represent these areas of petechial bleeding there, or hemorrhage within the lungs. The important thing in these two conditions, pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis, is that usually pulmonary vasodilators are often used to treat idiopathic pulmonary hypertension, but these are contraindicated in cases of pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis because that can result in fatal pulmonary edema. So that can be the significance of recognizing these entities. With pulmonary veno-occlusive disease, the small veins are obstructed. With pulmonary capillary hemangiomatosis, proliferation of the capillaries then also results in obstruction of flow through the pulmonary vascular system, resulting in pulmonary hypertension. Well, that's it for this lecture, and I thank you for your attention, and hopefully we will see you next time.